Wednesday, July 24th at 4 p.m. European time, around the same time of this webinar right now. We are waiting for you all there. And of course, we have next meeting with Dr. Mary Cohen on 6th of September, talking about errors in pediatric echo. I'm sure it's going to be a very interesting session. I hope all of you can join. We are supporting the Sick Kids Advanced Cardiology Education. They have a very nice program. It's a one-year program every Friday. So please take a look on the program and register if you think you're going to benefit for it. I'm sure it's going to be very nice. And now I'm just going to ask Ernie to talk a little bit about the Fetal and Neonatal Cardiac Symposium that's going to happen next September. Please, Ernie.
Three institutions, University of Illinois College of Medicine in Peoria, also Lurie Northwestern University and Rady Children's Hospital, UCSD have merged and are organizing this Fetal and Neonatal Cardiac Symposium year 2024, wherein many speakers from several institutions, both in the US and Canada, including Norm Silverman, who's here with us, will be giving talks on September 21st to 23rd. Those who are members of the Congenital Heart Academy and Fetal Heart Society will be given extra discount. But even without the discount, if you look at the website, you can go to Fetal and Neonatal Cardiac Symposium. Just Google it, year 2024, click on it, and you will see the registration and the speakers and the topics. It's a 3-day symposium, Saturday, Sunday, Monday, September 21st to 23rd, 2024 in Chicago. That's a very good time of the year for the Windy City. It's not as windy as the rest of the year. We'll see you there.
Thank you so much.
Ernie, is it virtual and physical, right?
It is both physical and virtual. We're giving priority to non-continental U.S. Participants for the virtual, but of course anybody could enroll for virtual. But of course you will be missing the city if you don't come to us.
Perfect. Thank you so much.
Ernie, it's Gil. Could you just give us that web address again, please?
Just Google Fetal and Neonatal Cardiac Symposium, Gil, and it will be the first one that you will see there.
Okay, I can type on the chat box for everybody so they can click later on it.
Thanks, Grace. Yeah, it came up, Ernie. Thanks.
But there's a special click to get the discount for the Congenital Heart Academy and the Fetal Heart. On an extra icon on that a brochure for the discount, 25% for the members of Congenital Heart, Fetal Heart Society, Fetal Hearts, and so on, the three institutions. Okay, I think we're ready to start, and you're most welcome to the 32nd series of the well-attended fetal series under the umbrella of Congenital Heart Academy. This is Rima Bader, Professor of Pediatric and Fetal Cardiology. I'm the organizer of this. I want to thank everybody in the Congenital Heart Academy for the great support. I want to thank all the lecturers that really helped us to sort of get the world on cardiology. And today we have a very, very special on the with a very eminent Professor Dr. Mike Seed. And I think most of us don't know a lot about the fetal cardiac MRI. And it is trained in radiology and pediatric cardiology in the UK and at Sick Kids in Toronto. His clinical interests include cross-sectional cardiac imaging and fetal cardiology. His research has focused on prenatal circulatory physiology and brain development in setting of congenital heart disease. I think this is just a little bit about Dr. Seed, and we're very welcomed and very, very honored to have you. And please share your screen.
Sounds
Sometimes
cool.
like it's harder to share Zoom than it is to do a fetal cardiac MRI. Is that right?
I'm just having to change my settings, apparently. Okay, let me try again.
At the bottom, there's a share screen.
How's that?
That's good.
Okay.
Ideal.
Perfect.
All right. Well, thank you very much for the kind invitation and introduction. And it's really a pleasure to talk to you about our experience here in Toronto with fetal cardiac MRI. And I just wanted to try and focus a little bit more on what emerging sort of clinical applications, and sort of start with our initial findings and move through more recent things. And so, you know, this is when we really first started around 2008. We were experimenting with trying to get some images of the fetal heart using MRI, and we used existing fetal MRI sequences. This is just a heavily T2 weighted sequence that shows fluid as being bright, and this is actually an image of the lungs, and this was a fetus with hyperplastic left heart syndrome with a restrictive atrial septum. And the lungs look quite abnormal here. You can see that there's some fluid in the horizontal fissures, and there's a sort of irregular surface of the lung. And then there are these sort of bright branching structures running through the lung, through the sort of interstitium of the lung. This is quite an abnormal appearance. This fetus actually died in utero and had an autopsy. And so we were lucky enough to get some pathology of the lungs. And here you can see on gross inspection a so-called cobblestone surface of the lung. And then on microscopy, just H&E staining, you see these dilated lymphatic vessels running through the lungs. And this is pulmonary lymphangiectasia. The importance of this finding, I think, is that is the underlying pulmonary vascular disease. And we went on to image a few more fetuses with left-sided heart disease and reported in this early paper. Again, on the bottom left, you can see an image of this of the lungs with pulmonary lymphangiectasia. It's sometimes referred to as nutmeg lung. It certainly is reminiscent of the cobblestone appearance that you see in other lung diseases on CT, shown on the bottom right there, and it's consistent with dilated lymphatics. These patients also have very low pulmonary blood flow, as you can see in the figure on the top right. The three patients, subsequent patients with restrictive atrial septum, we measured pulmonary blood flow, and it was very low compared with the other hyperplas in green and the normal controls in gray there. And I think this is reflective of the underlying issues in the lungs, which have been described, of course, in hyperplastic left heart syndrome with restrictive septum previously by Jack Rychik. On the left here, you can see muscularization of the pulmonary veins. The top image is a normal pulmonary vein, and the bottom image is in a hyperplastic left heart with restricted septum. You see the pulmonary vein walls are thickened here. And then also by another group, Mader et al., describing hypoplasia of the small pulmonary arteries. So again, the top image is a small pulmonary artery with a bronchus next to it. They should be about the same size, but in the hyperplastic left heart with restrictive atrial septum, there's underdevelopment and thickening of the wall of those small pulmonary arteries. So the lymphangiectasia is really a part of a constellation of problems that are caused by left atrial hypertension. And even in modern series, this is associated with worse outcome of surgical outcome in hyperplastic left heart syndrome. So this is a series from New York showing that the early mortality is higher in hyperplastic left heart syndrome with restrictive septum than other Norwoods. In fact, the radiologists at Children's Hospital of Philadelphia have worked very hard at trying to characterize the clinical significance of this finding. And here, again, sort of an independent risk factor for poor postnatal outcomes in the setting of congenital heart disease on this plot, showing the dotted line is those that had pulmonary lymphangiectasia on fetal MRI compared with other patients with congenital heart disease. And this has, of course, led some groups, including our own, to consider whether there's any fetal intervention to try to decompress the left atrium and allow for a normal sort of pulmonary vascular development. This is a paper that I was involved in, showing our early experience with stenting the interatrial septum in patients with this condition. And here you can see the stent across the atrial septum and flow across it there, showing that the shunt had been improved. And in fact, we have seen in some patients definite signs of improvement in the lungs on fetal MRI. This MRI on the left here was done at around 24 weeks gestation. You can see the pulmonary lymphangiectasia, a bit of pleural fluid there. And then following a fetal atrial intervention, a balloon in this case, at around 32 weeks, the lungs are looking much more normal. And this patient actually was born in quite good condition and has subsequently gone on to have a Fontan operation. And so, although the long-term outcome of these patients is still quite uncertain, certainly there are some cases that can do well with this sort of approach. With serial MRI, we've also been able to show improvements in pulmonary blood flow after a fetal atrial intervention, and improvement in the blood flow pattern here on fetal cardiac MRI. So the dotted line again is before the intervention. You can see very deep flow reversal in early diastole, and then following the intervention, a much more normal sort of flow pattern in one of the branch pulmonary arteries. However, you have to be aware that these interventions sometimes don't last. This is the VTI ratio of forward to reverse flow by Doppler in one of the branch pulmonary arteries. And you can see in over weeks, it's becoming more abnormal with a lower ratio of forward to reverse flow. And so you may need to repeat these interventions. And again, just in a limited number of cases, we showed improved survival following a fetal atrial intervention compared with patients that were managed without any fetal intervention. But of course, we're not just interested in looking at the lungs with MRI. We're also hoping to look at the heart. And this is the sort of latest version of the sequence that we've developed here in collaboration with our physicists. It's a technique that relies heavily on post-processing technology and a kind of mathematical approach to cardiac gating. And this is a patient with transposition. As you can see, if you follow the images from the top row, the aortic arch here, just below that, you can see the ductus arteriosus. You can see a relationship of the great arteries with the posterior pulmonary arteries and aorta anterior. You can see the pulmonary veins, the atrioventricular valves, and so on. On the short axis, you get a look at the ventricular function. You can see, again, the parallel great vessels with the head and neck vessels coming off the aortic arch. You can see the pulmonary arteries in short axis and a bicaval view there. And what we found is that if you wait until the end of the pregnancy, when the heart is relatively large, the fetal motion is relatively restricted, and these are the optimal conditions for fetal cardiac MRI, you can usually get this sort of reasonable quality of imaging where you can diagnose the cardiac morphology. And in fact, if you combine imaging data sets in several orientations into a kind of three-dimensional data set, you can then orient your imaging plane in any view. And I just show this image, this case, which is another fetus with transposition that was identified by fetal echo and was really having an MRI because of a research study. But I think it's just gives an example of how even complex intracardiac anatomy might be well visualized. So you can see a fairly normal looking four-chamber view, and even the three-vessel view here on first inspection, looks reasonably normal. But when you open out the long axis views, you can actually determine that the left ventricle is connected to the pulmonary artery there, and the right ventricle is connected to the aorta. So in fact, the great vessels were sort of side by side in this case of so-called posterior transposition. I think that this approach, is probably the way things will be going in terms of intracardiac imaging. And certainly transposition is an interesting disease to study with fetal MRI, and I've been lucky enough to work with our fetal cardiologists on some of the more tricky cases, like this one, in which we were fairly suspicious that there was very limited interatrial communication. As you can see on echo here, we really couldn't see any shunt at atrial level. And of course, I don't need to explain to this audience why that's terribly important in transposition, because in the delivery room, we're relying on an atrial level shunt for systemic oxygenation. So in this case, we employed an approach that we've developed in Toronto that, to try and assess the hemodynamics of the fetal circulation. And it's primarily comprised of these two techniques. On the left is cine phase contrast, which is a technique that we use for measuring blood flow. So in the three-vessel view here, we're targeting flow in the SVC. We want a short axis view of the SVC to quantify blood flow, rather like Doppler. We're going to use some post-processing on that, segmenting that vessel to quantify the flow in the vessel. And then on the right-hand side is an MR oximetry image, which exploits the different magnetic properties of oxy and deoxyhemoglobin to quantify blood oxygen content. And this is a so-called T2 map, which gives you a sort of visual indication of the relative oxygenation of the blood in the different vessels. So the brighter the blood, the higher the oxygen saturation. So in this normal heart, the aorta has higher saturations than the pulmonary, and the SVC has the lowest saturations. That is, of course, because of streaming of oxygenated blood from the umbilical circulation across the foramen ovale via the ductus venosus and into the left heart, as shown nicely on this human four-dimensional flow imaging, where we can see the red flow is the oxygenated blood coming back from the placenta, ends up in the aorta, whilst the bluer flow mainly goes, the deoxygenated blood from the lower body is mainly going into the right heart and out into the duct and main pulmonary artery duct and descending aorta. So in transposition, we see the same initial handling of oxygenated blood being streamed across the foramen ovale into the left heart, so that on this 4-chamber view, you've got higher saturations in the left heart than the right. But of course, because of the discordant ventricular arterial connections, we now have that oxygenated blood going into the main pulmonary artery and deoxygenated blood going into the aorta. And so usually in the case of transposition, we have higher oxygen saturations in the left heart. That blood is going to the lungs and the descending aorta, and bluer blood in the right heart. The oxygen saturations in these diagrams are indicated by the color coding. The circles with the numbers are blood flow measurements in as expressed as percentages of the combined ventricular output. So in this fetus with a restrictive atrial septum, we actually found a different pattern. First of all, our flow measurements suggested there was much less flow at atrial septal level, and our oximetry measurements suggested that very unusually, the saturations in the right heart were actually lower than those in the left, in keeping with that oxygenated blood that's coming back from the placenta, now going into the right side of the heart because it can't cross the foramen ovale, goes into the right side and the aorta. So the opposite pattern of the normal heart, and also the majority of patients with transposition. And based on the echo and MR findings, we took the unusual step of performing a balloon atrial septostomy in utero at 36 weeks gestation to try and improve atrial mixing and make for a more stable delivery. We had preparations for the baby to be delivered as part of this intervention if things didn't go well. But in fact, the intervention was quite successful. Here you can see the catheter and wire going across the atrial septum, and then here's the balloon being inflated across the atrial septum. And following that intervention, we in fact saw reversal of that pattern of oxygen saturations then with the left ventricle and right ventricle very similar, but the left slightly higher. And the flow measures suggested there was now a good shunt at atrial level. And the pregnancy continued for another 3 weeks. And the baby was born with oxygen saturations in the 70s, and then went on for a sort of semi-elective septostomy postnatally. So when another baby then came along with a similar concern on echocardiography, we again performed the fetal MRI. You can see the appearance of a rather sort of hypertensive looking left atrium here, very distended. And there's the atrial septum, looks intact and bulging towards the right atrium. In this case, again, when we did the oximetry, you could clearly see that the oxygen saturations here are higher in the right ventricle than they are in the left ventricle. And so this family was offered, again, a fetal atrial septostomy. They, in fact, elected to wait for postnatal management, and we sent a surgical team to the delivery room. And in fact, this baby was born with unrecordable oxygen saturations and became bradycardic soon after birth and was cannulated onto ECMO before getting to the cath lab for a septostomy and ultimately a successful arterial switch operation and a good outcome. This is another fetus in which, with transposition, in which there was concern about restrictive atrial septum. In this patient, the fetal MRI suggested that there were higher saturations in the left ventricle than the right ventricle. So we cautiously suggested that this baby might not require an urgent septostomy in the delivery room or ECMO or anything, although we did again send the surgical team with it, with an ECMO team. And indeed, this baby had reasonably good saturations in the 70s and could be transported to the cath lab for an semi-urgent septostomy. So just putting together some of the data from our experience with transposition. On the left is a diagram showing the difference between the saturations on the right and left side of the heart. So and the bars are at baseline and during an episode of maternal hyperoxygenation. We repeated all the measurements. And so what you can see is that those babies with restrictive atrial septum have higher saturations in the right ventricle than the left. Those babies with an unrestricted atrial septum have higher saturations in the left ventricle than the right. So the line in the middle is where the saturations would be exactly the same in the two ventricles. In fact, the trial of hyperoxygenation in these cases didn't really add to our diagnostic yield. And then on the right-hand side, again, this time we're just measuring foramen ovale shunting, and you can see that the foramen ovale shunting is lower in those fetuses with restrictive atrial septum than the ones with an unrestrictive atrial septum. So, I'm cautiously optimistic that this approach may add something to our assessment of these babies as we're trying to make suitable plans for delivery. And certainly we will continue to explore this avenue. I think it's quite interesting to consider that those babies those babies with restrictive atrial septum often also have restriction at the ductus arteriosus or abnormal flow at the ductus arteriosus, and may be at risk of pulmonary hypertension. And it's just interesting to consider this sort of hypothesis that we came up with several years ago, that initially in transposition you may have pulmonary vasodilatation due to oxygenated blood being presented to the lungs, but that may then increase pulmonary venous return and tend to restrict foramen ovale shunting and reduce ductus flow. And so you may then develop this situation, a bit like postnatally, where there's inadequate mixing between the two sides. And of course, in postnatal life, that leads to systemic hypoxemia. In fetal life, the hypoxemia would be on the left side of the heart and in the lungs, because oxygenated blood is coming from the placenta. And this could drive the development of aortopulmonary collaterals, further damaging the pulmonary vasculature. So the other condition that we've been quite interested to look at, as exploring this idea that we would try to augment or provide an adjunct to echocardiographic assessment, is in patients with Ebstein anomaly or severe tricuspid valve dysplasia. Here's an example. You can see the heart is very enlarged. There's a lot of tricuspid valve regurgitation. The lungs are compressed. In the most severe circumstances, you may develop, if you develop pulmonary regurgitation, where the right ventricle is not able to eject blood into the circulation, but in fact starts leaking, you can get the development of a circular shunt. Under both of these circumstances, we have measured very reduced pulmonary blood flow and reduced systemic blood flow, particularly in the setting of a circular shunt. You may have actually quite a good output of the left ventricle, but because blood is just circling round the aorta, the duct, back through the right heart and across the foramen ovale into the left ventricle again, even if you have quite good output of the left ventricle, you end up with a steal from the systemic circulation, including the cerebral circulation and the placenta. So here we categorize patients into controls, Ebstein with a circular shunt or without a circular shunt. And you can see those with the circular shunt may have actually a higher combined ventricular output, but they have lower SVC flow, lower descending aortic flow, and both groups have reduced umbilical vein flow. And in fact, this reduction in SVC flow is fairly unique to this sort of physiology, and we found associations between brain growth and cerebral blood flow, which we're measuring with SVC flow. And certainly, as we've gone on to image the brains of these patients, we've found evidence of poor brain development and growth and a lot of brain injury, like this white matter injury, leading to adverse neurodevelopmental outcomes. So again, you know, when you're in a desperate situation, you know, you may try new things like the non-steroidal anti-inflammatory drugs to try and restrict ductus arteriosus shunting in the setting of a circular shunt. And we reported a small series of these patients that we gave indomethacin to the mother. And here's one patient in whom we performed fetal MRI pre and post indomethacin. And you can see on the preoperative imaging, the SVC flow here is 80, the cardiac output 300, and we made a calculation of a circular shunt, which was 40%. But following ductal restriction, SVC flow has improved, and the amount of circular shunting has reduced. And, you know, I don't have any evidence to show that this improves fetal brain development or neurodevelopmental outcomes, but it certainly makes sense to me that this might then represent a sort of fetal neuroprotective intervention, as well as, you know, allowing the pregnancy to continue closer to term, which we know is likely to be beneficial for surgical outcome. And here is another patient that we recently scanned with a tricuspid valve dysplasia. In this case, there was actually pulmonary atresia, and this baby was followed from about 30 weeks on with weekly echocardiograms, and 2 MRIs were done, one at 29 weeks and another at 35 weeks. You can see that there was already some reduction in SVC flow and cardiac output at 29 weeks, but there was no high drops, and the baby was growing, and so we, you know, continued to manage conservatively. And then we did this scan at about 35 weeks, and we found dramatically reduced flows in all of these vessels that we were able to interrogate. And we actually thought that this must be a technical artifact, because we just had a scanner upgrade and we were setting all the fetal sequences. But in fact, the mother actually presented to her local hospital 5 days after this MRI, and with reporting reduced fetal motion, and the CTG was unreassuring. The baby was born by a cesarean section and born with in very poor condition, with APGAR scores of 1 and 4, and a severe metabolic acidosis, and required resuscitation, and has subsequently undergone a Starnes operation, and is still in our intensive care unit. So, you know, in hindsight, we should have acted on these flow measurements and delivered the baby there and then. But it just does give a suggestion that, you know, these very low blood flow measurements could be sort of harbinger of poor fetal outcome. And we've also been interested in, the relationship between fetal hemodynamics and outcomes, both surgical and neurodevelopmental, across a wide range of congenital heart diseases. And this recent report shows the surgical outcomes at our center for a group of diagnoses with cyanotic congenital heart disease. You can see that the Ebstein anomaly, these are the severe Ebstein anomaly, having the highest mortality and also hyperplastic left heart. And we actually found associations between combined ventricular output on fetal MRI, usually done in late gestation at around 36 weeks, with a surgical survival, and also then associations between both superior vena cava flow and cerebral oxygen delivery, so cerebral blood flow and cerebral oxygen delivery, which was available in a subset of the patients with early neurodevelopmental outcomes tested on the Bayley-3 at 18 months of age. And so in this study, SVC flow and postoperative hospital length of stay accounted for something like a third of the neurodevelopmental outcome variation. And so, perhaps starting to understand how heart disease is affecting fetal brain development in terms of substrate delivery, and how that actually is likely to have long-term consequences for neurodevelopmental outcome. So I'll just spend the last few minutes showing a few other cases. This is tuberous sclerosis with a large left ventricular tumor. The fetal MRI, fetal cardiac MRI, was somewhat helpful in confirming there was patency of the left ventricular outflow tract, which was quite difficult to see on the echocardiogram. And in fact, we could monitor the size of this tumor when we gave sirolimus to the mother, which actually resulted in some reduction in the tumor size. And then, that you have an opportunity to do brain imaging, which in this case showed the cortical tubers that confirm the diagnosis of tuberous sclerosis. So I think there's probably a role for combined imaging of brain and heart in that disease. And this is a fetus that had a diaphragmatic hernia and oligohydramnios and maternal body habitus and oligohydramnios really made the ultrasound imaging quite difficult. And so we were asked to have a look with MRI, and because there was a suspicion of heart disease. And in fact, we could see that there was a VSD and a sort of single outlet heart, and no central pulmonary arteries. And so, we felt suspicious that this was tetralogy with pulmonary atresia. In this case, that sort of gave the patient, the family, a bit more information about the heart disease and about the overall sort of disease. And this baby was born premature, and in fact the parents didn't pursue active management, and the heart disease was confirmed postnatally. So not the most uplifting sort of story, but showing that you've got an alternative way to look at the heart if you've got problems with fetal ultrasound that could just provide a bit more information. And under some circumstances, I really do think that fetal MRI can be giving clearer pictures of the fetal heart than echo, and that's really in late gestation, when you might get shadowing of the heart by the bony thorax, oligohydramnios. Those are the conditions under which MRI actually becomes easier. And so this was an unusual case of a right ventricular diverticulum. You can see it on short axis here, and you can see the inlet VSD that was accompanying that. I know David's on this call, and delighted that he could join us, because he has really pushed quite hard in terms of defining a clinical role for fetal MRI with this sort of angiographic imaging, which which uses some, again, clever sort of processing to get over problems with fetal motion. And here's a case he showed me with total anomalous pulmonary venous connection, really beautifully demonstrated, and as good as most neonatal CT scans that you could do in this sort of situation. I've been somewhat skeptical about the role of fetal MRI for anatomical imaging, but David remember showing me this beautiful image of a scimitar syndrome. You can see the anomalous pulmonary vein coming into the IVC here. And, I'd recently missed a case of scimitar with ultrasound. And so, you can start to see how that sort of imaging could help. And David has reported in the Lancet, additional findings with cardiac MRI in a proportion of patients undergoing fetal echoes, whether they are cardiac or extracardiac findings. So my take on the evolving clinical indications is that, interested in this disease for those babies that we're most worried about, particularly as they're coming up to delivery, babies that we don't know how they're going to do in the delivery room. Could there be a role for us to use this sort of unique physiologic information to help us plan those hours and guide and monitor fetal interventions that we might be considering under those circumstances. And certainly, there is an alternative way to look at the fetal heart now than ultrasound if there are problems from a technical perspective. I'd just like to finish by thanking a lot of people who have contributed to this work, and particularly Chris McGowan here is the physicist that has been working with us on this project for some 15 years or more, and really is the person who's developed the technical advances to make this imaging possible. And Jana Morrison is the fetal physiologist that we've been able to collaborate with to do a lot of the animal work, validation of the techniques and so on, as well as many other people, the fellows and nurses and so on that make this research possible. Thank you very much.
Thank you very much, Dr. C. Do you hear me?
Yep.
Just want to thank you. Beautiful presentation. Before we go further with a discussion, I'd like to introduce our four panelists. We have Dr. Lorna Brown, Professor of Radiology, Director of Cardiac MRI, Children's Hospital of Colorado, University of Colorado. And we have Dr. David Lloyd, a consultant in pediatric and fetal cardiology, Evelina, London Children's Hospital, Senior Research Fellow at King's College London. And we have Dr. Ernie Alborius, Associate Professor of Pediatrics at University of Illinois. And we have, of course, the father of this, the godfather of Dr. Norman Silverman, and he's Emeritus Professor of Pediatric Cardiology at Stanford, Honorary Professor at University of Cape Town as well. So now we open the floor for discussion. Bill, you had two questions while Dr. Seed. Can you unmute yourself?
You said my name, Prima, is that right?
Yes.
Mike, again, congratulations to you and your team. One of my colleagues, Michelle Udine, just said, you make it look so easy. And I know the work that you and your team have put into this. It's just fantastic. I have a question about fetal pulmonary vasodilatation and how you measure it. The postnatal teaching, as you know, is that alveolar hypoxemia and alveolar hypercapnia are the strongest pulmonary vasoconstrictors. And we know that alveolar hyperoxia is a pulmonary vasodilator. And we think that pulmonary arterial hypoxemia, or low PO2 in the pulmonary arteries, is not a pulmonary vasoconstrictor. Otherwise, all of our blue babies would have pulmonary hypertension. What's the mechanism of pulmonary arterial hyperoxia in, for example, transposition or maternal hyperoxygenation tests that vasodilates the fetal vascular bed, the fetal pulmonary vascular bed? And there's solid data for that, correct?
Yeah, there is. Yeah, I mean, and I can't take credit for any of that. It was all figured out by Abe Rudolph and his colleagues, and subsequently, people looking at the pathways. But yeah, certainly, if you increase the PaO2 in the pulmonary arteries in utero, it vasodilates the pulmonary arteries, and you get increased pulmonary blood flow. You're obviously not doing anything to the alveoli because they're fluid filled, but you get a dramatic increase in pulmonary blood flow in the acute setting, and we've measured this with cardiac MRI, and it's been measured on many occasions. And my understanding is that it's primarily through nitric oxide, increased nitric oxide production, which is signaled somehow by the change in PaO2. But there are other factors that affect pulmonary vascular tone, endothelin, thromboxanes, and so on. But my understanding is mainly the nitric oxide.
Yeah, that's certainly been studied on the endothelial side of the alveolus. It's
Right.
very interesting to me that it would be on the pulmonary arterial side. It's clearly seen. It's been seen many, many times. I was just curious how what that was from. Thanks. Appreciate that. I'm sure there's tons of questions. I'll pause for here.
The floor is open for discussion. I know it's a complex topic, and I'd like to hear from Dr. David Lloyd about his technique and the beautiful pictures that we've seen and the validity of what we've seen in clinical practice.
I think I just caught the question, but yeah, no, thank you, Mike. I think that was a fantastic talk, and thank you for the kind words about our work. I can just reiterate what Mike said, that we actually have a pipeline to recreate static three-dimensional models of the heart, which is obviously not very good for the intracardiac anatomy. We don't really see anything with that, but we get quite good reconstructions of the vascular anatomy. So that, for us, in our clinical service, has been quite a powerful adjunct to echo for a range of diagnoses. We are exploring lots of other techniques very similar to Mike. I had a question for Mike actually around that, which is, I think, on that point, really, I think you covered it really well, that fetal cardiac MRI has this just really broad range of potential applications. There's so many facets to MRI in general. And the way that it's applied, as we're talking about clinical applications, has been very variable. I think different centers have come up with different solutions. They have different infrastructure, different needs, and it's certainly not a settled debate about how do we use it. What's the position statement on fetal cardiac? It's not there. And that can be everything from, I think, as you covered at the end, people are talking about even using it as a screening tool where you have limited images, for example, right through to the sort of second level testing visualization, through to physiological understanding of conditions and applying that, through to even sort of neurodevelopmental outcomes way down the line. So it's a difficult question, but could you say where you think it will really fit as a kind of bread and butter clinical tool within that spectrum? Is it going to be all of those, or do you think something's going to come to the top? And a difficult second question is, how do we then sort of, if you like, prove that it's effective? But this is an expensive test, and there's a lot of infrastructure required. And a question I get asked a lot is, how do we then show that it's actually making a meaningful impact for our patients?
Yeah, thanks, David. And as you say, at Sick Kids, we haven't really done nearly as well in terms of exploring the role for anatomical imaging. And I think that's why I was referring to your work in that area. I mean, I do think that we just need a few good indications, and sort of we'll be away to the races because we'll be doing a lot more fetal scanning. And you know, I do think the lungs is very interesting in cases of pulmonary venous hypertension, because I'm starting to see cases where the Dopplers, you know, are worrying, and yet the lungs are looking okay. So I do think there might be, you know, a good role for triaging those patients with the combined imaging. And you know, these patients with transposition, which really are a pain, you know, in terms of you never know, you can never trust them when they're born, you know. At least here, you know, something to confirm that that there really is likely to be a serious problem when the baby's born, and even for us to consider fetal atrial septostomies. I mean, I think you can probably still get a baby with transposition that will be very blue, that had an okay shunt in utero, and we won't be able to exclude that from happening. But we will be able to kind of confirm that there really is a problem with the atrial septum prenatally. And we can really focus on making sure those babies are okay in the delivery room. And then, yeah, you know, this sort of monitoring of an extremely fragile circulation, where you don't want to deliver preterm, you don't want to deliver your Ebstein baby with a circular shunt preterm if you can avoid it, but you know, monitoring your non-steroidal and potentially pulling the trigger and delivering the baby when the cardiac output gets too low. You know, that baby didn't have high drops, but was dying in utero, and you know, the flow was actually the clue. So I'm really interested in that role where our imaging is much better at the end of the pregnancy, when ultrasound's actually getting harder to do, MRI is getting easier. We still don't always know what to say to families about what's going to happen to their child in terms of, you know, what operation we're going to need to do. So we should be working on refining, you know, predicting neonatal physiology and surgical outcomes.
Great.
Thank you so much. Now, I think we're getting at a very high level of discussion. The question goes now back to a little bit of the more basics of the technique and the applicability of the MRI. Now, Dr. Seed, now, my understanding, pardon my ignorance, that when you do the cardiac MRI, this is ECG gated. We have some questions from the panel. And how do you do the gating? I mean, let's talk about the people would like to know worldwide about the technique of acquisition. We've talked about the application and what it means clinically, but we have some of the audience, they wanted to know how you take your imaging and a little bit about the technique, please.
Yeah, so you don't have the ECG. You need cardiac gating to do decent cardiac imaging on the whole. So you need an alternative. The one that's really taking off is this Doppler device, which is basically just a cardiotocogram that's MRI compatible, and you feed the signal straight into the magnet for gating. And that's just been approved by Health Canada, and so we're starting to experiment. I've used it in animal models. The approach that we took, which, you know, is a totally different one, where everything is kind of done